So I think probably a few of you know me, maybe not everyone, but Dr. Hantus. I do mostly ICU, EEG, and epilepsy emergencies on a daily basis at the Cleveland Clinic. But more than that, I also have a very personal connection to epilepsy in that my wife has epilepsy and my youngest daughter have epilepsy. So I'm going to be talking about a lot of technical things. We're going to talk about MRIs and EEGs and all the things that happen in a story of epilepsy. And I'm not doing this to try to make you all experts in these things, but these are the things that if you have someone that you love with epilepsy, um, that is going to be going through this, this is what's going to show up on your my chart. This is what is going to be discussed when you see your doctor, right? So this is how a story of epilepsy flows. Okay, so I'm here to educate about those things, and certainly I want to answer any question that you have. And a lot of my goals, especially if you see me in the clinic, is educating you about your disease. Okay, so I'm going to tell a story about a patient with an epilepsy emergency and talk a little bit about how we treat those. So let's start with some Renaissance art because that is another passion of mine. So this is Saint Valentine, and he is witnessing a patient having a generalized tonic-clonic seizure on the floor here. So this is from the 1500s. In fact, as long as we've recorded human history, the earliest was the Sumerian clay tablets. They have discussed seizures and status epilepticus from all of our recorded history. So this is something that has been with us from the beginning. Now, when you have a seizure like this, it's very apparent. Everyone can see that, and everyone knows that something needs to be done. Okay? Unfortunately, sometimes the seizures don't always present like this. Okay? Sometimes they present like this. You see a man who is unresponsive, and he's got a black leg. So this is from the bubonic plague. And you see they're removing the leg. There's a prosthesis here. The patient is unresponsive. Now, is he having seizures or not? We don't know because EEG wasn't discovered for another 600 years. But with EEG, we're able to follow these seizures. And what actually happens is people start out like this, and then their body loses the ability to have seizures. And it's called electromechanical dissociation. Okay. And so then when you finally present the care and people are doing stuff for you, then you're often just in a coma. Okay. But if there are seizures going on, that's causing progressive brain damage. And those are things that we want to address to give you the best prognosis of waking up. Okay. So the way we learn is by stories. And so I would like to present one story that'll go through this lecture. And it's about a patient that I saw in 2022. And it's a 66-year-old left-handed male. He had a history of high blood pressure and substance abuse. And he presented with a severe progressive headache. He told his wife that he has this terrible headache, and his wife had worked in our pediatric monitoring unit for many years, and the headache kept getting worse and worse. Then he started to vomit, and then he started to drag his left side. Okay, so when you have a severe headache, everyone knows that that's uncomfortable, but there are some signs you want to look for. So vomiting is one sign. It sometimes happens with migraine headaches, but vomiting often is a sign of increased intracranial pressure. Okay, so something is bad happening inside the brain. Okay, now when you started getting focal signs, which, the left side was weak, then we're concerned that, not only is there increased intracranial pressure, there is something on the right side of his brain which makes the left side of his body weak. So his wife called the paramedics, and then he slipped into a coma um, at that time. So this is his CT scan. And I told you there'd be lots of pictures and studies. And like I said, just for education. But there's a little Mickey Mouse that lives in the brain down here. You'll see it better in other pictures. But there's little ears here that are right next to the memory structures. And this white stuff here is blood. Okay, so this is looking down the top of the brain. This is the eyeballs up here. This is where the ears go. And so you see this blood that starts actually on the right side. I know this is the left side of the screen. This is the right side of the brain. We neurologists try to make everything confusing. But the right side here is full of blood. And then these black spaces in the side are also full of blood. So this is the lateral ventricles, these part here. This is the third ventricle. And down here is the fourth ventricle. Okay, so what you're seeing is blood in these lateral ventricles and third ventricle, and blood here in this right side of the brain, which causes the left-sided weakness. Okay, so this is called a intracerebral hemorrhage and a intraventricular hemorrhage. This is the 1st of March of 2022. Okay, so he's taken to the operating room. They do an angiogram, and what they find is an aneurysm that's at the base of his intracerebral artery, and this is repaired. Okay, so they figured this was an aneurysm caused by high blood pressure, genetic tendency, and also contributed by his substance use. And so that was fixed. However, the patient did not wake up. And when they brought him back to the ICU, he had a new finding. And his finding was his eyes would look only to the right. Okay? They would not look anywhere else. They were just stuck on the right. Okay? Now, when you have eyes that are stuck on one side, there's two things to consider. One is that if they're looking toward the lesion, okay, in this case, the lesion is mostly on the right, then that is often because the eyes are unopposed from the frontal eye fields on the other side. But basically, you look at your lesion, okay? That's typical. Now, if you have a seizure, the eyes actually go the other way, right? And they start looking towards the left in this case. So the eyes looking towards the right was not very concerning to us. But on the new CT, he does have a lot more swelling, okay? So before I showed you the little Mickey Mouse, even though it wasn't very clear, it is even less clear now. And there's lots of more grayed out areas because of the swelling. And you can see this black up here, and that's air that was introduced when they were doing the angiogram and craniotomy. Okay, so now we're going to talk about brain waves. And so if you've had any personal experience with epilepsy or loved one experience with epilepsy, you see that we like to glue wires on people's heads and then record the electrical activity underneath their skull to kind of figure out what's going on. Okay, so this is what we did in this case. We put the electrodes on, we started recording the brain waves. You can see that he was not responding to us. We held his eyes open, we're stimulating his foot, we're getting very little in the way of responses, okay? But mostly there's dysfunction on the right side, and I know the little numbers and things are really small here, but the odd numbers are left, even numbers are right. And there's a little chart over here that is a little bit easier because the red is the right hemisphere, blue is the left hemisphere. So at the bottom here, you see a bunch of red, which means that the slowest frequencies are in the right hemisphere. And so you have bilateral cortical dysfunction, maximum in the right. And that's the kind of thing you'll read on my chart and things like that in the future. Okay. Now, in addition to that, right-sided dysfunction we talked about. There's also some epileptiform discharges, okay? So this is what we call a spike or a sharp wave. And what this means is that 100,000 neurons are all firing at exactly the same time, okay? And this can be because of a well-developed epileptogenic focus, like in medically intractable epilepsy. It can also be due to injury, okay? So when you injure the brain, then it will start having these synchronous discharges, which can actually cause seizures. Okay, so this is 100,000 neurons all firing at the same time. They make this sharp wave. Okay, so we knew the potential for seizures was here, but we didn't see any seizures at this time. Okay, so then we did see some of this rhythmic slowing, sharply contoured. So we knew the area was irritable. Okay, so it's dysfunctional. It's having these sharply contoured, which means that there's synchronous discharges from these neurons. That means this area is very upset and irritable from all that blood that is present. So then we have our first seizure, okay? So this is 65 hours after the etiology, which was the hemorrhage, 36 hours while on the continuous EEG. Now, just for your reference, when we get EEGs in these settings, they're often very short EEGs. You may just get 20 minutes or 1 hour, and if you don't see seizures, you may stop them. And at big institutions, we'll often do 24 hours of EEG to see if there is a evidence for a seizure or those things. Okay, in this case, if we had done the 24 hours and stopped, we would have missed the seizures. Okay, and I will talk about the high-risk etiologies for these delayed seizures. And of course, one of those etiologies is hemorrhage. Okay, so what you're seeing here is the area of maximum dysfunction, which is the right, and then you're seeing fast activity on top of it. Okay, these neurons do not want to fire fast. Okay, this is a trauma response for these neurons. They're firing very quickly, and this is the seizure. Okay, so we'll go through more seizures, and you can see these big red bars here. Each one of these are seizures. Okay, and this is half an hour, so this is about 4 seizures per hour. Okay, and again, this is the area of maximum dysfunction, and then you see fast activity coming out of that. Okay, and then this is more seizures. You can see 1, 2, 3, so 6 seizures per hour. And so my point is, it took us very long time to record seizures, 36 hours on the continuous EEG, even longer from the etiology. But the seizures weren't just 1 or 2 isolated seizures. This is, 4 to 6 seizures per hour. Okay, so lots of damage happens from all these seizures that happen, and if you don't monitor long enough, you will miss them. Okay, so let's go through one of these seizures. I know I said there was fast activity at the beginning, so you had the slow, then you see this fast activity, very many little bumps here. But what we see here is evolution in frequency. So it goes from fast, and then as the seizure goes on, it gets higher amplitude, more spiky, and slower. Okay, and this is the neurons. They have the very fast activity. They lose the ability to do that, and they start slowing down and have slower and slower discharges. And this pattern is actually what causes damage to that site. And you'll see some of that. So here is more high amplitude, spiky activity in the neurons. And then you start to see at the end of the seizure, these bigger spikes, almost like those in-between seizure spikes that we saw at the beginning. And then you'll see the seizure has a definite end to it. Okay, so big spike, big slow spike. And this is area of damage. Okay, and this is why people who have lots of seizures and these kind of things have progressive memory loss, cognitive dysfunction, and those type of things is from the damage from this kind of seizure activity. Okay, so This is a chart that was actually made by Dr. Tryman in the 1990s, but it's very illustrative. And so a lot of seizures start with those generalized convulsions, like I showed you in the picture, and they may evolve into just some twitches of the arms, sometimes the eyes, sometimes the face, and then eventually they go into something called electromechanical dissociation, where the brain is still having a seizure, but the body no longer responds, okay? And so the seizures first start as isolated seizures, they get longer, they merge together, and then they start in these periodic discharges. But the main thing I want to show you is this says brain damage. And you can see that as long as you're convulsing, this brain damage goes up very quickly, okay? The non-convulsive seizures are lower, but still this is damage going up and up, and we are in the frame of hours, okay? So remember, this takes just a very short period of time to accumulate this damage, okay? Within 60 minutes to hours, you're talking significant damage already. Okay, so status epilepticus, or these acute repetitive seizures that we were recording here, is a medical emergency. And the prognosis, or the outcome, is really dependent on what the cause was, the underlying etiology, or I'm sorry, I should say, and the time spent in seizures or status, okay? So the etiology in this case was the hemorrhage, okay? The time spent in status is this time we're recording on EEG and we're trying to treat it and we're trying to stop them, okay? Now, the key here is that we have no control over the etiology, right? So if you come in with a herpes encephalitis, if you come in with a hemorrhage, if you come in with a stroke, all these things can cause seizures, but we don't, we can give you prognosis based on those, but we can't affect it, or very little that we can do about it, okay? But the time spent in status, those are the things that we can affect, okay? So the more aggressive we are at diagnosing these and treating them, then the better outcomes you will have, okay? So this is protecting the brains of epilepsy patients. Okay, so what is the definition of status? So 30 minutes of continuous seizure activity was a research diagnosis or definition. And basically, if you're going back through your charts and you're looking for cases of definite seizures, then 30 minutes is certainly qualifies. You'll see this in studies and things like this. But certainly, we would never wait for 30 minutes and then start treating you after 30 minutes, okay? So once you get to 5 minutes, we do not expect the seizure to stop on its own, okay? So we're treating it like status epilepticus after 5 minutes, some people even 3 minutes. So 3 to 5 minutes is typically what we're going to call that on a clinical basis, okay? What's refractory status? This is when we give the first line medicine and the second line medicine, and then you're still having seizures, okay? That's refractory status. Okay, so why does this happen? So basically you get persistence of abnormal excitation and then ineffective recruitment of the inhibition. So too much gas and no brake, okay? So what is the gas and the brake? Well, brakes are things like GABA, which is an inhibitory synaptic channel transmission. And then the gas is like the glutamatergic excitatory synaptic transmission. So basically, this can come from a non-limbic or limbic source, comes to an area called the perihippocampal gyrus, which I'll show you on an MRI. And then this goes to something called the dentate, then goes to the hippocampus, which is your memory structure, and then back to the perihippocampal gyrus. And this goes around and around and around. So this is the amplifier for seizures in your brain, okay? So seizures may start in one little area, but they get amplified by the temporal lobe, okay? That's why temporal lobe seizures are so common. And so here, this is a restricted diffusion. So you're looking at areas where their membranes have been exhausted, so they've been discharged so often they can no longer maintain ion gradients. So you can see here, this is that Mickey Mouse I was telling you about with the ears of the Mickey Mouse here. And that is right next to the memory structure. So this is the amygdala and hippocampus. And you can see it's bright. Okay, so that bright signal is from acute seizures going on. And that's that circuit that I was telling you about, which is the hippocampus, parahippocampal gyrus, and dentate is all right here. Okay. So how do we know that it's seizure and not stroke? Well, once we treat the seizures, then that signal goes away. Okay. So those membranes are able to get their ions back, recharge, and that abnormal signal goes away. If this was a stroke, that would not happen, and that area would just be gone. Okay. So with seizure, we have a chance to save the tissue. Okay. And that's what we're trying to do here. Okay. So the pathophysiology is your opening ion channels. I'm sure you've heard about sodium channels, calcium channels. These are all the things that we talk about when we're talking about different medicines. Neurotransmitters, and then some receptor trafficking. And the important thing is that the brake, the GABA receptor, is actually taken away from the synapse, and the glutamate, which is the gas, is actually moved into the synapse. So the more you seize, the worse it gets, okay? And that's the maladaptive response. So I could give you a cartoon of that. So basically, this is the beginning, like before you have seizures, and you have GABA, which are the brake, and glutamate, which is the gas, and you have these receptors along the postsynaptic membrane. And then the seizure comes from here, and all these neurotransmitters get released into the synapse. And then what you see is these little white triangles, which are the glutamate or the excitatory gas receptors, are going into the synapse, and these green triangles, which are the GABA, which is the inhibitory, and the brake, are being removed. And this is called a clathrin-coated pit, but basically it's being removed from the membrane. So the longer you have seizures, there's no more brakes, okay? And only excitatory stuff is there, so the seizures perpetuate themselves, okay? So that's the real danger. There's all kinds of seizures and status. You can have generalized status, you can have focal status, you can have myoclonic status, you can even have psychogenic status that's caused by stress. Okay, so when we put someone in the ICU, we have lots of stuff on them, and you can see all kind of wires and those things, and mostly it's for monitoring the heart rate, their blood pressure, the oxygen saturation of their blood. And those are things that cardiorespiratory function we have studied in ICU patients for many years. But we have often neglected what we are actually interested in, which is the brain. Okay, so having these electrodes on the brain tells us what's actually happening up here. Okay, so a very necessary part of taking care of a patient with a neurological issue. Okay, so this is a study I did back in January 2009, December 2010, and we did the first 1,000 patients. It was actually 1,123 patients, and we found that 215 of those, or 19%, were having seizures, and most were without any clinical signs that we could see. But that's not the whole story. And so if you look at 10 years of our experience, I've been there for a little while now. And then 2008, it was when I started this program, and we had about 60 patients having these frequent seizures. Okay. 2009, almost 100. 2010, over 100. Okay. It keeps going up until we have 450 in 2018. 2023, we had over 500, almost 600. Okay. So each year we find more patients who are having seizures. Okay. And so that's two things that are happening. One is we're monitoring more patients. Two is we are looking for high-risk etiologies, okay? And so this is not just seizures, we're also finding things like sharp waves in the same fashion. So let me just show you the blue are the seizures, and the line here, which is the number of patients we monitored. Okay, so at the beginning, this was only in the 250, 300 per year type of thing, about one per day new patient, okay? And then as time went on, we got monitored more and more people. And most years, when we monitor more people, we find more seizures, okay? But there are some years, 2013 to 14, we actually monitored less people, but we actually recorded more seizures, okay? And so that is from targeting the right people, okay? You can see the same thing in 15 to 16. So if you know who to monitor, you don't have to keep just monitoring more and more people. You find the seizures because you know who is the most at risk, okay? So this is a publication that we have on this. And like I said, we were finding markers for targeted monitoring. Some of those markers, number one is mental status, and this is on 14,000 patients that we were looking at. And what you find is that awake patients, only about 10% of those were having seizures, okay? When they start getting sleepy or lethargic, it goes up to 15. Stuporous, 18.6. Coma, 27.2, or about 1/3. So 1/3 of the patients who came unresponsive were having seizures, okay? 1 out of 3. And that's a very big number. And that is, irregardless of why they were in a coma, okay? So if you're a neurologist and you're on the neurology service, you know that we have a fair number of patients who are in comas, okay? So a lot of these patients are having seizures, and this is how that we can target the right people to monitor. Okay, so what are the high-risk etiologies? So stroke, hemorrhage, tumor, CNS infection. Those are the 4 big ones, okay? And you can put these two things together, okay? So if you have a stroke, which, if the right MCA is stroke, you have left-sided weakness, but you shouldn't be in a coma. So if you have a stroke and you're in a coma, then you can put these two things together because you already know stroke is a high-risk etiology and the person has the highest risk based on mental status. So stroke with coma is very high risk for seizures, okay? So this is how we decide, how to put people on monitoring. Okay, so let's get back to our story. We had our patient who was having these frequent seizures in the ICU after a delayed recording. And so first we gave lorazepam. So always we give benzodiazepine first, then we gave levetiracetam, then we gave lacosamide, and the seizures did not stop. Okay, so this is what we call refractory status epilepticus. Okay, and then we had to give midazolam drip, which is basically general anesthesia. And it's just like when you call IT support, the first thing they say is, did you turn it off and turn it back on, right? And so this is kind of what we're doing to the brain, right? You have to kind of shut the brain down and then let it reset, okay? So that's what the midazolam drip is doing. Okay, so the question is how long can we let people have seizures? Okay, so this is not for outpatient seizures. This is for patients in the hospital with these non-convulsive seizures. And what we found is that if there's less than 10 hours of seizures, most of the patients eventually go home. Okay, 10 to 20 hours of seizures, most of the patients are permanently disabled. Okay, and then greater than 20 hours, most of the patients end up deceased. Okay, so you can see the time pressure here, right? Is that 20 hours, you could hook up someone on EEG and you don't read it till the next morning, it could be too late, right? So you have to be much more responsive to that, and you have to be able to continuously update and affect treatment, okay? So, because that may be the only time you have. So what actually causes death in these status patients, right? Why do they die? And so, they do get hyperthermic. You can get up to 42 degrees after 9 hours of status, but the hyperthermia rarely contributes to death. There is catecholamine release. And so when you have the catecholamine release, especially in a right insular seizure, then that could be associated with the heart stopping or bradycardia followed by cardiac arrest. And certainly that does contribute to a number of seizures, but only a small number, okay? Then there's acidosis. The pH will drop to less than 7, but that is actually something that is cardioprotect or neuroprotective and does not actually contribute to death. What does contribute is that something called the NMDA receptors, which is a excitatory cascade, goes to activation proteases, caspases, and something called programmed cell death. Okay, so what happens is you get atrophy and cell death of the neurons in the brain, and that contributes to death. Okay. And so seizures are much easier to treat at the beginning. Okay, the sooner you intervene, the better your response is. And this is why a lot of our focus in the last couple of years is to be getting rescue medicine that's available to patients. Okay, the availability rescue medicine used to be you come to the emergency room. You have to be seen in an ambulance, taken by the ambulance to the emergency room. Then they start an IV. Then you get rescued. Okay, very laborious. Then they did a study, I'll tell you about, where they had EMS giving an intramuscular injection. And now we have the ability to give rescue medicine directly to patients. Okay, I'm sure a number of you already know about these, but we have the ability to give midazolam in a nasal route and diazepam in a nasal route so that we can do this rescue right away. Okay, this will be very effective at stopping the onset of status. Okay, and then this early status, established status, and then refractory status. This is where we were. And then when you have 60 plus minutes, it's very hard to treat, and you often have to use the anesthesia. Okay, so terminating the status is always our goal. There's protocols, which I'll go over. But there's other things you have to consider besides just terminating the seizures, okay? You also have to manage the underlying etiology, okay? In our case, they had to go in there and clip an aneurysm, right? If we didn't clip that aneurysm, he could have kept on bleeding, his brain would keep on swelling, he would herniate, and he would die, okay? Now, that would not help. Even if we stop the seizures, dying is the ultimately bad outcome, right? So you have to address that underlying etiology, okay? But stopping the seizures is, the way to save as much brain as possible when you've addressed the underlying etiology, okay? Then there's seizure-related complications, okay? Not in this case, but sometimes you can be unresponsive, lay on your face for a number of hours, and you get something called rhabdomyolysis, right? Your muscles break down. When you're in the ICU for a while on a midazolam drip, you may not be able to walk for several weeks or maybe several months. Okay, you have to learn how to walk again. Okay, so the other thing that can happen is you get blood clots that can start in your legs, go to your lungs, called a pulmonary embolus. These are all things that can happen and have to be treated along with the seizures. Okay, and then we have to prevent seizure recurrence because just because we put you under a midazolam drip, we turn the brain off, right? We're going to try to remove that midazolam, turn the brain back on, and when we do, we want the brain protected. Okay, we're not just going to use the same medicines we did with that were failing. Okay. So how do we approach the first medicine? The good news is we do have some class 1 level A evidence, which means they were large randomized controlled trials. And the first one was the VA cooperative trial, which established lorazepam as the first dose. And then the Rampart, which is the one I told you about, where the ambulance personnel could come out and give you a injection with the auto-injector of midazolam. And these were shown to both be effective. The midazolam was actually better as far as the efficacy due to the speed only. If they were given at the same time, they were equal, but the midazolam was given much faster. And that's why we are such advocates for having a rescue medicine at home. Every person should have a rescue medicine at home. Okay, so this is the old one from 1994. We only had a few drugs back then. And so it was lorazepam, then fosphenytoin, then phenobarbital. Okay, and we didn't have all the fancy medicines we have now. And so then comes the next trial called the ESET trial, or Established Status Epilepticus Treatment Trial. And basically, you had to give the benzo first, the lorazepam or midazolam. And then if you failed that, they were giving seizure medicines. Okay, we gave levetiracetam, valproate, or phenytoin. Okay, and it turned out they were all equally effective. Okay, so those are the next medicine that you will get. And you may see those in your chart or your patient's chart, and those are the common next steps. Okay, but we have lots of them, not just the ones that I listed in the trial, including some new ones, lacosamide, brivaracetam, perampanel. These are ones that don't have as much data, but they are often used in clinical practice as the third line. So how did we decide where to go after the trials have stopped? And so basically you have to balance mechanisms, okay? So what I always tell my patients is that, we want to use different mechanisms to attack multiple angles to get your seizures to stop, okay? We'll use sodium channel drugs, use SV2A drugs, GABA drugs, calcium channel, AMPA antagonists. We put all these together, okay? And so we don't want to use a lot of them from the same category because that just makes you toxic. You walk like a drunk, your eyes get double vision, you don't feel so good. That's the toxicity on the medicine, okay? And what we want is no seizures and no side effects. So this is kind of more of a modern demographic for treating status, which includes lots of different benzodiazepine options, and then phenytoin, valproate, levetiracetam, and then midazolam if we need it. Okay, so back to our patient. Patient was weaned off the midazolam but didn't wake up. The levetiracetam was decreased. Lacosamide was reduced. The continuous EEG didn't show any seizures or epileptiform discharges, but he remained unresponsive. Okay, so how do we handle reducing medicines in these cases? So we start with the ones with the most encephalopathic potential, or as you might want to think of it, as the ones that make you the most sleepy. Okay, so the ones that make you the most sleepy: phenobarbital, Depakote, levetiracetam, lacosamide, phenytoin, in that order. Okay, so this is how we try to stop them, and we try to discharge people on only 2 medicines if possible. Sometimes people require more. Okay, and so this is just a paper that we published that shows that if you have these seizures, then one of the major effects of these seizures is actually that you develop epilepsy. Okay, this person did not have seizures until they had this hemorrhage. Then with the repeated seizures in the ICU, they actually developed epilepsy. Okay, and so that number is about 48% when they have PLEDs and seizures. So what are the factors that increase the risk of developing epilepsy after acute symptomatic seizure? So seizures on the continuous EEG, as I discussed, PLEDs, or these frequent epileptiform discharges, a structural lesion in the brain, like the hemorrhage, Epileptiform discharges on follow-up EEG, and there could be some genetic disposition as well. Okay, so let's look at the follow-up CT as we're finishing up here. So what you can see is there's more damage on the right side. See this little dark area, this dark area, and you can see that this area here is more damaged on the right side. And pay particular attention to this little space here. Okay, here's the Mickey Mouse. There's the ear. Right next to the ear is the memory structure. Okay, so look at the size of the memory structure on the left compared to the right. And the way you can see that size is the blank space around it. Okay, so you see this big black area? This means that this area was selectively destroyed or targeted. Okay, versus the one on the left side has much less damage. Okay, and that's because we had a lot of right-sided seizures. Okay, the right-sided seizures cause that destruction of the neurons in that right hemisphere, particularly in that right hippocampus, from that circuit of amplification that I was telling you about. Okay, so what was his exam when he left the hospital? This is March 29th. He had been there for about a month, for all of March. So when he leaves, this is a neurosurgery exam, so I'll interpret it for you. So his eyes open on noxious stimuli. He doesn't follow any commands, okay? The pupils were equal, but they did not track, they did not attend, which means that they opened his eyes, he would not look at them, okay? He would not look at anything in particular, they just stared straight ahead, okay? He didn't have a gag, his arms would not move, and his legs would not move, okay? So no motor on the upper extremities, no motor on the lower extremities, doesn't follow any commands. The only thing he had was if you gave him a painful stimulus, his eyes would open, okay? Not very encouraging, okay? Now, let's look at July. So July, this is his EEG. You can see that there's still some dysfunction on the right, but we didn't see epileptiform discharges. But says shows 2 thumbs up when asked. Okay, so he's following commands on the EEG. So let's go to his exam. This is the neurologist exam as opposed to the neurosurgeon exam. So you see a lot more details. But a mental status, he's alert and interactive, oriented to person and place, but didn't know the time. His cranial nerves were good. His motor exam, he had 4 out of 5 strength on the right, 3 out of 5 on the left. So he still has some left-sided weakness, but he has good motor movement on both sides. Just the left side is weaker. And he was in a wheelchair, unable to walk because his left side is weak. Okay, but he's awake, he's talking with us, he's following commands, and he has a little bit of left-sided weakness. Okay, so that's a dramatically better exam. Okay, so my point is treating these seizures, catching them early, is what can give us this kind of improvement and good outcome. Okay, so this is just some things we published on these delayed seizures. I won't go into all of that, except for the seizures went up in a linear fashion for the first 36 hours, and the highest risk was these multiple brain bleeds, okay? And then I will just leave you with this diagram we already talked about, is that each year that we have recorded and diligently tried to find more criteria for these seizures and treat them aggressively, we have found more and found more people to help. So 2018, we were able to find 450 people that we could help. And so I think that's the message here, is that the status epilepticus is a epilepsy emergency, but first you need to find out that it's happening and then treat it aggressively with the benzodiazepine and those first-line medicines. And with that, I will take some questions.